I'm Linda. I'm the designated doctor for Sheffield, and I'm also a consultant paediatrician working in community paediatrics and the looked after team. So I'm going to talk about children looked after and care leavers and why they matter today. So aims and objectives: to understand who children looked after and care leavers are, to consider the impact of trauma and challenges faced, outcomes the children looked after, and I'm going to talk about specific groups of children, so the care leavers and unaccompanied asylum seekers. And then, if I get a chance, responsibilities to the children looked after and consent. I tried to fit in quite a lot of the intercollegiate guideline requirements for you, but obviously I've only got a little time to talk, so I've tried my hardest. So definition of children looked after. So they're those who are in care of a local authority for more than 24 hours. There was, in March 23, there was 83,840. When I looked at the last number from the RCPCH, it's 93,000 now, which shows the significant increase. And in Sheffield at the moment, there's 444 children placed in city. There are 221 of our children placed outside the city, and we have another 218 placed in our city from other local authorities, so it's quite a large number. Although that is similar to those of last year, I think. And care leavers, there's someone who's been in the care of the local authority for 13 weeks or more, spanning their 16th birthday. And last year, in March again, there was 48,050, so again, we're looking at big numbers. Many people think that the definition should be anyone who's been in care at any point as an adult has left care, because the experiences don't go away, so they still have the additional needs. And now support is available up to 25 years if the young person wishes it. So why do children and young people come into care? So two main routes: parents may ask for help, or it may be because the child is at danger of being harmed, and this is the most cases occur from this route. If you look at the chart, the red one is related to abuse, physical or neglect, or sexual or emotional, and that's by far the largest category at 65%. There can also be related to family and acute stress, family dysfunction, parental or child ill health or disability, or absent parenting. The small green, is related to unaccompanied asylum seekers. The background reasons are so important to understand what's happened to them and how we can support them moving on. So risk factors of being in care. So children who are already vulnerable are more likely to be abused. Certain factors increase their likelihood, such as disability to prematurity and special educational needs, exposure to adverse childhood events. So all these things, they've always got these background risk factors, and then things just seem to get worse. I'm going to talk a little bit about adverse childhood events, but I'm sure you know loads about this already, so I'm going to go through it quite quickly. So there's stressful events occurring in childhood, things like domestic violence, parental mental health concerns, family separation, being abused or neglected, a member of the household being in prison. Why is it so important to think about these factors? Well, children in care often have 4 or more ACEs in their background, and health inequality is stark. If you look at the table of impacts, those with 7 or more ACEs are 11 times more likely to become alcoholic, twice as likely to have heart disease, and 19 times more likely to attempt suicide. So they're really important to consider, and it's really important to do our bit to promote this health and act on any health concerns when we find them. So children and young people basically have poorer outcomes than their peers who are not in the care system, and a large study in England and Wales concluded that those who have been in care during childhood had a higher risk of mortality long after they left care on average, and this was mainly from unnatural causes. So I'm going to talk specifically about care leavers, because the transition is really important, and to get this right, it's a really difficult stage for all young people. They often describe it as leaving care as like being on a cliff edge. They often feel abandoned, unsafe and isolated. One poignant, really to me, quote from a care leaver was that I felt my parents had died when I became 18 because they just left care and there was no longer any support for them. So I think that's really important to consider when trying to support these young people. What kind of challenges can they face? Financial instability, housing, problems with education and seeking training, relationships. So we have a Bright Spots meeting where we meet with care experienced young people, and one of the biggest things they bring up is related to mental health and loneliness, and that's one thing they'd really like support with. So that's one thing that's really important when we're thinking about the transition for these young people. And the government, because of all these concerns, introduced the Care Leavers Covenant in 2018 to support them to become more independent. So what is the impact? So this was from a publication by the Care Leavers Association. 7 times more likely to die before they're age 25, 33 times more likely to be involved in sex work, 40 times more likely to be involved in the criminal justice system, 4 times more likely to have special educational needs, and 25 times more likely to become homeless. So these are really significant impacts. As well as this from the publication, there's other things showing increased rates of mental and emotional health concerns, developmental physical health and neurodiversity concerns, teenage pregnancy. In one paper I saw there was 25% in teenage girls who were care leavers, substance use and exclusions from education. So they have a range of health problems to address, so I suppose this is one of the things to think of when you're seeing them in appointments. Can they have a longer appointment to just consider all these needs? I know you're not going to get it done in one appointment, but it would be a chance to try and support them. So the reason we bring the young people into care is to try and give them a better life and improve their situation. But if you look at all these outcomes, they're just a bit concerning with how we can support them. For this reason, we're trying to start a pathway to primary care for care leavers and care experienced people to improve the transition. So I wasn't involved in this pathway, but I've been asked to talk about it today because it will be a new thing, hopefully starting in November 24. Don't worry, there will be more information. I think there's going to be information packs and briefing sessions. And then obviously feedback afterwards to us to make it better. So all children in age 17 have their last review health assessment. Everything happens as normal. The information will go to the GP for ongoing support. The only difference will be that at that point we'll try to gain consent for the child to have care experience status. So if they consent, we'll send a notification to primary care to ask this to go on their record, so this can be noted and ongoing support can occur. That's the idea. Anyway, what else did the young people want when we spoke to them? They wanted to see the same GP every time if they could. They wanted longer appointments to be able to talk about their needs. They wanted the information to be clearer, so for things to be written down, for there may be pictures. So these are all things that we could do to help support them. They also wanted trauma-informed care, so just some understanding and some empowerment for them. So the Sheffield's Care Leavers Union, again, they're a group of care experienced young people who came together specifically to help improve the support we could give them in the system. I won't read it all out, it will be sent to you, but it's really important to think of the ways that they would help things like, and that again, some of them I've already mentioned. One of the things, the first one, having a way of easily knowing what our records, from our records that we're care experienced, that's the whole point of the pathway, so people are aware and can provide more support. Having regular checks of what their contact details are, because these children or young people move around a lot, so they can miss appointments. That was one of the other things they mentioned, it's not on their flexibility if they miss appointments. Knowing about mental health support, because as I mentioned before, this is a really important concern to them, so being given leaflets and suggestions and support for this can be really helpful. They may struggle with communication, which I've already mentioned, and they wanted some clear information given to them. So now moving on to unaccompanied asylum-seeking children. They're young people under 18 who have travelled from another country and who become separated from their usual parent or carer. So they have a specific set of needs, which are I've mentioned on here, lack of background information. If we don't know the background information, we might not be able to help them with their health needs, mental health and trauma, PTSD, and this can be either from their journey, it can be from what they faced in their own country, or even the isolation they felt when they arrived in this country. So it's really important to address sleep difficulties, dental problems, nutritional needs, musculoskeletal. Immunisations are mostly uncertain. Who knows if they're incomplete or not, so they often require redoing. Communicable diseases, so they need testing, and there are standard screens. Sexual and reproductive health and health promotion, sexual health promotion as well. A lot of them may not have had this before. Cultural things such as genital mutilation, language barriers, social isolation. That's a really important thing that I often see, which causes big barriers for these young people. Knowledge of the UK health system, they may not know how to access when they have health concerns, so they may need some support for this. Cultural needs such as diet and religion, and discrimination. They're entitled to GP and free medical treatment, and there's a HC1 form that the social worker can help them to fill out for dental treatment, access to glasses, contact lenses, and also travel to get NHS treatment. Also, so talking about the social isolation and the language barrier, I've just put in some resources that we found really helpful for specialist services. So there's a Red Cross to help unite them with their parents for contact or significant others. But you have to remember that some don't always want contact with their parents. Refugee counsel and solace for emotional health counselling. Chili Peps peer support and can really help with integration into local communities. There's the Happy Group, the Unix Centre in Sheffield. They've got football pitches, dance studios, and again, just a good way to integrate young people with others. So apart from those specific groups, just supporting children looked after in general whenever you see them in a clinic setting or any setting really. Remember their background trauma and reasons for care and the impact this has. So their physical, emotional, educational, social needs. They may have had previous neglect of health needs, and they've got general poor outcomes. Any early support you can give them with their health needs or health promotion is really important, especially as these kids can often come in and out of care. So anything you can do now for them might get done, whereas if it gets delayed, it might be missed. The trauma-informed approach and listening to the voice of the child, this helps to make services more accessible to them and can have a positive impact on the outcome. And always consider mental health. So for any Sheffield child placed in Sheffield, there's the MAPS team who the social worker can refer to, but otherwise other children would go through their CAMS route. And don't forget safeguarding. Even when they're in care, they're still vulnerable. So this was something I learned from recent training. I had always considered safeguarding, but the extent of the problem I don't think I realised. So this was a safeguarding review of children looked after, 98 children, it was serious incident reviews, 19 died, 79 were suffering serious harm, sexual abuse suffered in 49, physical abuse in 23, neglect in 4, and in 3 cases the child looked after caused harm to others. And these were children or young people living with foster carers, adopters or special guardians, and they should have been protected. So there's also increased risk of contextual safeguarding, criminal and such as criminal and sexual exploitation, so we need to be on the lookout for those. So never stop looking is the answer. So moving on to responsibilities. So what do we need to do in the NHS? So basically we need to help the local authority to fulfil their responsibilities as corporate parents. And what does a corporate parent do? It has to make sure that the care you're providing for these children and young people is as good enough as you'd want for your own child. So basically we have to ensure appropriate arrangements and resources are in place to meet physical and mental health needs and provide coordinated care for each children and young person. But the important thing is that you would want it to be as good as that it would be for your own child. Statutory framework, it'll be in the slides, but I'll go over it briefly. So initial health assessment, so this is by our team, child looked after team. Supposed to be within 20 working days. Obviously we can't do it without consent and they are often delayed. but they will get it and it will have a health plan, so it can start sort of care planning for them. If they're under 5, every 6 months they will get a review health assessment, and that just checks from the previous assessment that we have met their needs, that there's no ongoing needs, and that if any new issues have arisen for them. If they're more than 5, then this occurs annually. And then the LAC review, so this is a whole care plan. They occur every 6 months, but more frequently to start with, and this is about social care, about education, and about health coming together in one review to make sure we're meeting all the needs of these children together, so those are really important. It's chaired by an independent review officer who just makes sure we are meeting all these needs. Who can give consent? I don't know if that was mentioned at the other, no, okay. So those are the parental responsibility. So that's obvious. Or those who have been given delegated authority may be able to give consent. So that depends what order they're under, which I'm going to go into very quickly in a minute. Young people at age 16 or 17 are presumed to be able to consent for themselves, as long as they are appropriately informed. Young people under 16 can if they're GILIC competent. Now, with the orders, I'm only really mentioning this now because recently we've been asked to do initial health assessments with inappropriate consent, so it might occur with yourselves as well. So I'm going to quickly talk about this. If a child's under an interim court care order, the social workers can consent, but they need reviewing every 4 weeks. Full care order, social workers can consent and they can override parents. The problems happen when they're voluntary accommodated, so this is section 20. So only those people who had parental responsibility prior to their came into care can continue to consent. So these are the birth parents or whoever they came from. So you would not be able to, if a social worker signed, you would not be able to do a health assessment for these children. UASC are presumed able to consent for themselves if they are in the correct age group, because they're often over 16. If not, a treatment order may need to be sought. Adoption orders or special guardian orders are easy because the parental responsibility has transferred to the special guardian or the adopter. And that's just us in the safeguarding team, apart from me, because obviously I missed myself off. By mistake, that was. So there's a list of resources that you can, well, us really, so how to contact us. I haven't actually put the CLAS team on because this was an ICB presentation, but the CLAS team at Centenary House, if for any medical advice, we'd all obviously love to talk to you as well. And what the take-home message is. So children looked after and care leavers and why they matter. So unmet health needs, they have inequalities and disadvantages, and they continue despite being in care. Consider the challenges they face and ongoing poor outcomes. I think there's a real role we can have in health promotion and acting early on any health issues to try and improve these outcomes. Always have professional curiosity, the ongoing risk of safeguarding concerns. That's something, if we can act on again, might improve things for these children or young people. Trauma-informed care, listening to the voice of the child. This might make services more accessible to them. It might make them want to come back more. It might make them more compliant to whatever you would like them to do. It might just help with their outcomes. And check the correct consent. Record if a child is in care or if they agree for care experience status with the new pathway that's coming in, just so everyone is aware and so we can support these children or young people to improve things for them. And that is the end.